The topic of my presentation is oral rehydration solution. I am myself Dr. Pramod, Bhalerao, Associate Professor in the Department of Pharmacology at the Patil Medical College, Kolhapur. So, my presentation is about oral rehydration solution, in which we try to cover rehydration, because in cases of diarrhea and dehydration, there is loss of electrolytes and water. So, our main purpose in treatment of diarrhea and dehydration is rehydration. So, the priority measure of acute diarrhea is prevent and reverse salt and water depletion, because in most cases of acute diarrhea there is loss of salt and water. In majority of cases there is only this is the only measure needed. Rehydration can be done orally or intravenously. So intravenous rehydration, it is needed only when fluid loss is severe, that is more than 10% body weight. In other cases, if the dehydration is less than 10% of body weight, intravenous rehydration is not required. Now, if the fluid loss is mild, that is 5 to 7% body weight, or moderate 7.5 to 10% body weight, oral rehydration therapy can be instituted from the very beginning. So, oral rehydration therapy can be given if the dehydration is mild or moderate. What is the rationale of ORS composition? Oral rehydration is possible if glucose is added with salt. It capitalizes on the intactness of glucose coupled sodium absorption. Because if we give glucose in oral rehydration solutions, it causes absorption of sodium also. So this is the rationale of giving glucose with sodium. Principles governing composition of oral rehydration solution: it should be isotonic or somewhat hypotonic. Total osmolarity between 200 to 310 milliosmol per liter. Diarrhea fluids are approximately isotonic with plasma, which is 290 milliosmol per liter. The molar ratio of glucose should be equal to or higher than sodium. Excess glucose will be utilized in absorbing sodium ions present in the intestinal secretions, but not exceed 110 millimole. So, glucose osmolarity should be higher than equal to or higher than sodium, because glucose is required for absorption of the sodium in the GIT. But glucose concentration should not be more than 110 milliosmol, because it will cause increase in stool volume. In a potassium 15 to 25 millimole and bicarbonate citrate 8 to 12 millimole should be avoided to make up the losses in stool. In diarrhea, there is loss of potassium ions and alkalis like bicarbonate citrate. So to cover the losses, we also add potassium and bicarbonate or citrate to the rehydration fluids. WHO, World Health Organization, recommended standard formula in 1984. So the World Health Organization had given a formula in 1984 during times of cholera pandemics. So at that time they have prepared a formula for dehydration cases that contains sodium 90 millimole, potassium 20 millimoles, chloride 80 millimoles, citrate 10 millimoles, glucose 110 millimoles, and the total formula had a osmolarity of 310 millimole osmolarity per liter. Trisodium citrate was included in place of bicarbonate because bicarbonate had chances of caking. It had developed into powder and it caked, and it developed a brown color due to formation of sulfuric compounds with glucose. It had a short shelf life. So that is why bicarbonate was replaced by citrate. WHO formula 1984, if given with children, given for children with non-cholera diet, had a chances of developing periorbital edema due to excess sodium absorption, because the sodium content is high, up to 90 millimole per liter. Based on the sodium contents of enterotoxic E. coli stools, many pediatricians favored 60 millimole sodium and 90 millimole glucose ORS. So due to this complication of periorbital edema due to high sodium concentrations, many pediatricians they were of the opinion to reduce the sodium concentration up to 60 millimole of sodium. Yeah. New formula WHO ORS was formulated in 2002, which contains low sodium and low glucose ORS. It was released in 2002. A combined analysis of study using this low osmolarity ORS has revealed that the stool volume was reduced by 20% and incidence of vomiting by 30%. So what happens in World WHO formula in 1984? It contains high sodium and high glucose. Because of high sodium contents, there was increased chances of vomiting, and due to high glucose concentration in old formula, there was increased chances of increasing stool volume, and also there were chances of periorbital edema due to high sodium concentration. So this new formula has reduced sodium and glucose concentration. It also permits faster water absorption, precludes risk of hypernatremia, and is cheaper. So this new formula reduces the risk of hypernatremia, that is increased sodium concentration in the blood, and this new formula is cheaper. The new formula ORS has proven to be effective and safe in cholera as well. So this new formula can be used in cholera patients also. The WHO and UNICEF have recommended replacement of standard 310 milliosmol per liter ORS formula by the new 245 milliosmol per liter. So 1984 WHO formula was 310 milliosmol and this new formula is 245 milliosmol per liter. So this new formula WHO ORS contains sodium 75 millimole. Older formula contains sodium of 90 millimole, potassium 20 millimole. Older formula also contains potassium of 20 millimoles, chloride 65 millimoles. Older formula contains chloride of 80 millimoles, citrate 10 millimoles. Older formula contains citrate of 10 millimoles, glucose 75 millimoles. Older formula contains glucose of 110 millimoles. So many changes have been made in this new formula. They try to reduce sodium and glucose concentration, especially to prevent the complications of hypernatremia, periorbital edema, increase in stool volume, and increased chances of vomiting. Due to these complications, this new formula contains low sodium and low glucose. Potassium is important constituent of ORS since in most acute diarrhea, potassium loss is substantial. As we see in most cases of diarrhea, there is loss of potassium ions. So to recover this potassium ions, we give potassium ions in ORS. The base bicarbonate citrate lactates is added to correct acidosis because alkali loss is due to alkali loss in stools. Most of the alkalis are lost in stools like bicarbonate, citrate, lactate, and this increases the chances of acidosis. So to prevent the chances of developing acidosis, we give bases like bicarbonate, citrate in the ORS fluids. The base may independently promote sodium and water absorption. So this is another advantage. The bases bicarbonate, citrate, lactate, they increase sodium and water absorption in the GIT. The base-free ORS has been found to be equally effective in rehydrating, but correction of acidosis is slower. Some experts consider base as a non-essential constituent of ORS, but if present, it may be beneficial, especially in severe cases with overt acidosis. So most of the scientists, pediatricians, they are of the opinion that these bases are not non-essential components of ORS, but if they are present, it may be beneficial to cover the acidosis. Administration of oral rehydration therapy. Patients are encouraged to drink ORS at the interval of half to 1 hour intervals. Initial 5 to 7.5% body weight volume equivalent is given in 2 to 4 hours, 5 mg per kg per hour in children. So initially we should give as maximum as possible. Thus, due to volume depletion, provide an adequate driving force. So if the patient gets thirsty, he may be given as an ORS as and when required. Subsequently, it may be left to demand, but should at least cover the rate of loss in stools. In a weak child who refuses to drink ORS at a desired rate, it can be given by intragastric drip. Restoring hydration should be aimed. So if the child is severely dehydrated and if he refuses to take the oral rehydration therapy, then we can insert an intragastric tube, and through that intragastric tube we can do ORS feeding. ORT is not designed to stop diarrhea but to restore and maintain rehydration, hydration, electrolyte and pH balance until diarrhea ceases, mostly spontaneously. So most of the cases of diarrhea are due to viral causes. Some cases may be due to bacterial causes. But our aim in diarrhea is mostly to restore the hydration, and most of the cases of diarrhea they cease spontaneously. Preparing and administering ready-made ORS. So in medical stores, ORS sachets are available for making in 1 liter water. So first we have to wash hands with soap and clean water to prevent the contamination of ORS. Then pour all the powder from the 1 sachet of ORS into clean container that will hold at least 1 liter of liquid. So first in empty 1 liter jar, we have to pour the ORS. Pour 1 liter of clean drinking water, boiled and cooled, available into the container, and mix it. So first we have to pour ORS. After that we have to pour the 1 liter water, which should be boiled and cooled. Why water should be boiled? To kill all the bacteria and viruses present in the water. Use all the prepared solution within 24 hours, because after 24 hours there are chances of bacterial and viral contamination. If ORS is still needed after 24 hours, make a fresh solution. Steps for preparation of homemade ORS. Suppose if you don't have ORS sachet and if you need ORS immediately, then we can also prepare ORS in home also by washing hands with soap and water prior to preparation of the solution. In a clean container vessel, mix 1 liter of drinking water, half teaspoon of salt, 6 teaspoon of sugar. Stir till the content dissolve in water. Use all the preparations within 24 hours. If ORS is still needed after 24 hours, make a fresh solution. So homemade ORS preparation is very easy. First we have to take water, which should be boiled and cooled to kill all the bacteria and viruses. After it is boiled and cooled, we have to add half teaspoon of salt, 6 teaspoon of sugar, and we have to stir it until all the salt and sugar gets dissolved, and we have to use the solution within 24 hours. After 24 hours, we have to discard the remaining solution to prevent the bacterial and viral contamination. Non-diarrheal uses of oral rehydration therapy. Oral rehydration therapy can be used in post-surgical, post-burn, post-trauma, maintenance of hydration and nutrition in place of IV infusion. So in post-surgical patients, there is electrolyte and water loss. In post-burn and post-trauma cases also, there is electrolyte and water loss. So in these cases, we can use oral rehydration therapy. In heat stroke, in summer season, there are high chances of heat stroke due to high temperatures. In heat stroke, there is loss of electrolytes and water. So to restore the water and electrolytes, we give oral rehydration therapy. During changeover from intravenous to enteral elimination, we can use oral rehydration therapy. So this is about my presentation about oral rehydration therapy. And last point I would say, if a child has diarrhea, we shouldn't encourage mother to continue breastfeeding. The mother should not stop breastfeeding. Thank you.